Welcome to the presentation for the launch of the Global Antimicrobial Resistance Surveillance System GLASS report, early implementation 2017 and 2018. My name is Barbara Tornimbene. I'm one of the technical officers working for the GLASS team here in WHO. So why AMR surveillance? Well, we know that antimicrobial resistance is increasing and spreading around the world, and that anyone in any country can be affected. So surveillance is a key for collecting information that can be used to assess the spread and magnitude of AMR, to inform burden of disease estimate, and to drive local, national, and global actions. So WHO step towards global systems are summarized below, and they initiated with the commissions of the Global Report on Surveillance in 2014, which summarized the status of AMR surveillance globally. The report showed a lack of harmonized, standardized information on AMR in most countries around the globe. And to that, it followed then the development of global standards for surveillance in 2015, which are contained in the GLASS manual available on the GLASS website. After 2015, in 2016, WHO established the global surveillance system and it started the GLASS implementation. And last year, GLASS launched his first data core, and in 2018, early 2018, the first report was published. As forward step, GLASS will conduct and continue to conduct special studies, particularly to assess impact of AMR in human health and inform burden of disease, and to test the development of AMR surveillance in limited resource settings. So what is GLASS? Well, GLASS is the first global system to collect official national data on AMR in selected bacterial pathogens that cause common infection in humans. It was requested by the WHO member states through Resolution 68.7, and it was launched in October 2015. It supports the standardized approach to the collection, analysis, and sharing of AMR data. It collects epidemiological variables such as age, gender, infection origin, and clinical and microbiological data. Data on antimicrobial consumption and food chain related to AMR are and will be included in the GLASS mandate. And GLASS is currently in its early implementation phase, which started in 2015 and ends this year. And this implementation phase will inform the changes in the methodology which appear in 2020 with the new GLASS phase. So what is the purpose of GLASS? So the objective of GLASS are to foster national surveillance system and harmonize global standards, to estimate the extent of AMR globally by monitoring selected indicators, to collect data needed to inform and estimate the AMR burden, to routinely analyze and report global data on AMR, to detect emerging resistance and its international spread, to inform prevention and control strategy, and finally, to assess the impact of these interventions. So GLASS, it's based on a case-finding surveillance system and collects results from sensitivity testing of specimens sent routinely for diagnostic. And its rationale, it's based on the concept that a specimen type can be used as a proxy for infection. GLASS targets 4 anatomical sites: bloodstream infection, urinary tract infection, gastrointestinal infection, and genital infection. It collects information of 8 target pathogens causing common human infection, and it proposed a list of antibiotic combination to these pathogens. However, national surveillance system can include this combination according to their priorities, and you can see on the table of on the left the list of the pathogens that are included in GLASS, which are E. coli, Acinetobacter species, Klebsiella pneumoniae, Staphylococcus aureus, Streptococcus pneumoniae, Salmonella, Shigella, and Neisseria gonorrhea. So what data does GLAS collects? Well, GLAS collects information on the status of national AMR surveillance systems, specifically on indicators as overall coordination, surveillance systems, structure and quality control, and AMR data for the 8 priority human bacteria pathogen isolated from clinical specimen, blood, urine, stool, and cervical and urethral specimens. GLAS also collects population data as the overall number of patients tested for specific specimen and age, gender, and infection origin, hospital versus community of the patient that have been tested for AMR. Currently, as December 2018, 71 countries are enrolled in GLAS, 6 are in progress of enrollment. In order to enroll in GLAS, there's a need for a national body commitment in sharing data on the status of national AMR surveillance and, if available, share AMR data at least for one surveillance site and at least for one indicator. So, GLAS data calls. Well, the first GLAS data call was open in April and closed in June 2017. The information collected during the first data call were summarized in the GLAS report Early Implementation 2016-2017. The report contains information of the status of national surveillance system of 42 countries and AMR data summarized for 22 countries. It shows the value of reporting both microbiological and core epidemiological information, as we said, gender, age group, and infection origin. And 5 countries were also able to provide population data to allow for the calculation of AMR frequency in the tested population. The second data call was open in May this year and closed in July. As you can see from the 2 maps, on the top we have the 2017 enrollment for the first data call, and on the bottom the 2018 enrollment for the second data call. There is been quite a significant increase of country enrolled in GLAS, going from 42 for the first data call to 68. And in particular, in terms of participation, we have seen this year a growth in low-income and low-medium-income countries, providing not only data on the information of their national surveillance system, but only on AMR rates. So the second report was generating using information of the second data call. It's the early report 2017-2018. We have seen a 64% increase in country enrollment and more than twice of the number of countries submitting AMR data compared to last year. 13 countries that last year were able to provide only information on the surveillance, on the national surveillance system, were able to provide AMR data this year. And 11 countries compared to 5 countries last year were also able to submit the population data that allowed the calculation of the frequency in the tested population. So I'm just going to show a few slides summarizing the results for the report this year. These are just results that we consider of particular interest and we have picked for this presentation. All the results are more than details in the report and also on the GLAS website and GHO, and I will show the link in the later slides. So for the status of national surveillance system, as we said before, we collect 3 indicators: overall coordination, surveillance system, structure and microbiology laboratory quality control. These results are summarized in the report by regions, and they are connected to the core component that GLAS suggests for the implementation of a functional AMR surveillance system, which are the existence of surveillance sites, the presence of a national coordination center, and the establishment of a national reference laboratories. So as you can see this year from the graph below, Most countries have actually developed and implemented AMR national surveillance plans, and more countries have actually approved budget for it. As you can see in the graph below, the blue describe the AMR national surveillance plan existing with budget, and the green the one that existing without budget. But as you can see, in most countries, there's very few countries with a non-existing AMR national surveillance plans established. More countries have established or are in process of establishing national coordination center and have designated their national laboratory reference laboratory, as you can see from the graph on the left. Blue and green represent established or in progress establishment for the National Coordination Center, and on the right we have the designation of the National Reference Laboratory. As you can see, most countries have actually designated their laboratories. In terms of quality control, we have seen that almost all national reference laboratories participate in an external quality assessment scheme, EQA, as you can see from the graph on the left, where blue stands for EQA provided. And the AST are mostly run according to international recognized standards. UCAST and UCAST CSIs are presented in the graph on the right in red and orange, and you can see particularly in Europe, UCAST is the most used standard, and the light blue represents CLSI, and you can see that in the other region is generally the most common recognized standards used for AST. In terms of AMR data, GLAS is very careful to take the data that are provided by the country and to consider their representativeness, the quality and their completeness. And therefore, for these years, again, we have decided to not go into a very thorough analytical approach of the data, and we don't do any comparison of AMR rates within regions or between countries. However, as you can see from this table, in terms of progress of reporting compared to last year, we received data for a much higher number of surveillance sites. You can see on the column of the right the number of surveillance sites that have reported for 2018. The hospital surveillance sites are still the higher number. However, we have quite significant numbers of outpatient clinics that are submitting data. And on the bottom, you can see also the increase in the number of patients for which we actually have retrieved information of AMR. As you can see, bloodstream infection and urinary tract infection are the most prevalent infection for which AMR and AST results are reported, followed by gastrointestinal and sexually transmitted infection. And overall, this year, we have data submitted for more than 1.7 million of patients. All data submitted by GLAS can be viewed and are available free online, both on the WHO Global Health Observatory to our data visualization page and in the GLAS report published in the GLAS website. But also we offer a report supplementary material which are available, and the supplementary material contains all the data provided by country, specifically the number of isolate reported and tested for each antibiotic, stratified proportion of non-susceptible isolate, proportion of isolate with unknown AST result, and stratified frequency of non-susceptibility in the tested population. This is to show that all the data that come to GLAS are then available freely to the public. GLAS keeps developing. A lot of work has been done this year to keep moving and growing. Specifically, new models and tools are under development. The GLAS Emerging Antimicrobial Resistant Reporting, or GLAS-EAR, the Monitor and Antimicrobial Consumption and Use module, special project on AMR for gonorrhea, called specifically named Enhance GASP, AMR surveillance in the food chain and environment in 2017-18, in line with the One Health approach to AMR surveillance. New GLAS web tools were developed to improve reporting, data visualization and analysis, and new IT modules design was started. Specifically, the emerging AMR reporting EAR module was launched in 2018. It's open to people in charge of national AMR surveillance and all constituencies that might discover new type of AMR of potential relevance to public health. And it aims at facilitating timely information sharing on the detection and emerging AMR and stimulating technical discussion for coordinated action. The WHO Global Report on Antimicrobial Consumption was published in 2018. It contained information on volumes of sale of antimicrobial medicine that can be used as a proxy for use in the population, and is presenting 2015 data on sale of antibiotic for 65 countries and area. In relation to enhancing One Health AMR surveillance, the WHO Integrated Global Surveillance on Extended Spectrum Beta-lactame ESBL E. coli Tricycle Problem project was launched. The first draft version of the protocol is being piloted in 4 WHO regions, and the result of this pilot phase will inform the development of the GLAS tricycle modules. Finally, in terms of the development of WEBS tool, particularly for the AMR in human module, we have developed new analytical and data visualization tool and export functionality. As you can see, this is a screenshot from the first page of the human health module in the GLAS IT platform. The enrollment overview tool and the validation report tool and the country profile tool were launched. The enrollment overview to allow the viewer to select regions and identify and show on the map enrolled country stratified by their income level. So here, for example, we have the 3 African countries enrolling GLAS for low middle income. The validation reports allow country national focal point to visualize the data overview of the data that have submitted, also stratified by age, gender, origin, and also to visualize the AST results. And the GLAS profile, country profile tool, allow country to generating the GLAS profile and the graphical representation of the AST results that are going to be present on the country GLAS profile, and validate the profile before this is actually published through the GLAS report. Ongoing development for GLAS, definitely a consolidation in its methodology to achieve better representativeness, more complete data, and to better translate the result into policy. To work and keep developing the module for line-listed individual data in the GLAS IT platform. The module was already open last year. It's going to be available to the Euro countries next year, and to other countries that want to start trying submitting individual data. GLAS is also developing the methodology and launching the AMR surveillance in invasive fungal infection, and is working on protocols for special study to assess burdens on AMR disease. So this is how the GLAS IT platform will look this year. So as you can see on the left, we have the antibacterial resistance in human, which will allow to the submission of both aggregated data and individual data. We have the EAR module, we have the antimicrobial consumption module. In 2019, we will launch the EGASP, the enhanced gonorrhea project module, and the tricycle module. All the development and the work that GLAS is undertaking is strongly supported by partners. GLAS worked through WHO network with partner support. Specifically, we are supported by the GLAS AMR collaborative platform with partner technical institution and the WHO AMR surveillance and quality assessment collaborative center network. And these partners offer key support for country capacity building to conduct AMR surveillance, to foster participation of country in GLAS and to the GLAS development and dissemination. So in conclusion, consideration for this year, well, GLAS relies on continued data sharing as well as global collaboration, harmonization and coordination between all partners involved in the implementation of AMR surveillance. Some countries still face huge challenges to building their national surveillance system, and improvements are urgently needed. However, more and more countries are working towards achieving a status that will enable them to report data in a more complete and systematic manner. And the last final point is that the assessment of frequency rate by age group and infection is still a key to inform and direct mitigation strategy to control AMR. So, in conclusion, for this year, we have seen the early implementation phase, 2015 and 2019, is an essential step for the GLAS revision in 2020. It has identified the necessary methodological step in order for GLAS to achieve better quality, robustness, and representative not only of the reported data, but also the produced results. The comparison of AMR patterns over time, reliable estimate of the magnitude of the problem are still a key feature and are absolutely needed for the next step of GLAS. And GLAS is still very much involved and pushing for the country's full ownership of their data and their active participation in any methodological change the GLAS will face, because it's essential for country to then be able to use what GLAS generated in order to inform their control strategy. So finally, GLAS is an essential system for the monitoring and global for the monitoring of global AMR trends and the identification of AMR drivers. More information on GLAS and Synergy can be found on the GLAS website on the link that are shown in the slides. Also, information it's available on other WHO AMR surveillance initiatives that have been very useful for the GLAS development, and the GLAS constantly monitor for its development. And these are the HIV drug resistance, the MDR-TB surveillance, the malaria drug resistance and response, and the influenza virus resistance. I would like to thank you all the countries that have participated to the data call, and they keep supporting GLAS, and the future country that will enroll in GLAS and provide information to us. All the partners, the technical people, and the colleagues here in WHO that have supported the work of the report. The editors and the team at the Global Health Observatory that help us with our data visualization, and finally all the colleagues in the GLAS team. And we hope to continue working together to establish a stronger and broader global AMR surveillance system to help for future control of the issue. Thank you.